There exists a particular and profound tragedy in the history of modern medicine. A tragedy that emerges when desperation to treat serious mental illness, combined with limited understanding of neurological mechanisms, produces medical interventions of extraordinary brutality that cause severe harm while being justified by anecdotal observations, and by the hope that suffering might somehow produce therapeutic benefit. This is the story of insulin shock therapy, a psychiatric treatment in which patients with schizophrenia and other serious mental illnesses were deliberately injected with massive doses of insulin, doses designed to produce severe hypoglycemia and unconsciousness, doses that induced diabetic comas lasting for hours, comas that caused seizures and brain damage and that killed patients at measurable rates. Insulin shock therapy represents one of the darkest chapters in psychiatric history, a period during which hundreds of thousands of patients suffered brutal treatment justified by the belief that inducing medical crises might somehow cure mental illness, a period during which the medical establishment abandoned principles of harm prevention and adopted treatments of extraordinary cruelty. The story of insulin shock therapy reveals how desperation, how institutional authority, how the power of medical institutions can combine to justify practices of extraordinary harm, how ethical constraints can be abandoned in pursuit of hope for therapeutic benefit, how the most vulnerable patients, those suffering from serious mental illness, can be subjected to brutality in the name of treatment. The discovery of insulin shock therapy occurred in 1927 through an accident that would transform psychiatric treatment for decades. Manfred Sakel, an Austrian physician and psychiatrist working in Vienna, was treating a young diabetic woman with psychosis using various medications. In an attempt to treat the patient's psychiatric symptoms, Sakel administered insulin to the patient, apparently with the intention of inducing a mild state of hypoglycemia that he believed might have therapeutic effects. However, Sakel miscalculated the dose, administering a dose far larger than intended, a dose that produced severe hypoglycemia, and that caused the patient to lose consciousness and fall into a deep coma. The patient's blood glucose crashed to dangerously low levels, producing a state of severe metabolic crisis. The brain was essentially starved of glucose, the fundamental fuel that the brain requires to function. The patient's consciousness faded, her body became rigid, she experienced convulsions and seizures as her brain reacted to the severe glucose deprivation. The patient was rescued from this medical emergency through the administration of glucose, which rapidly restored blood glucose levels and allowed her to regain consciousness. When the patient regained consciousness, Sakel observed something that would fascinate him and that would drive his subsequent research. The patient appeared to have experienced an improvement in her psychiatric symptoms. The patient seemed more coherent, seemed less agitated, seemed to exhibit some reduction in her psychotic symptoms. Sakel, observing this apparent improvement, became convinced that the insulin-induced coma had produced therapeutic benefit, that deliberately inducing severe hypoglycemia and unconsciousness might be an effective treatment for schizophrenia and for other serious mental illnesses. What is remarkable about Sakel's response to this accident is that he did not recognize it as a cautionary tale, did not understand the event as a demonstration of the dangers of inducing severe metabolic crises, did not recognize that subjecting a patient to near-fatal hypoglycemia was extraordinarily dangerous and potentially harmful. Rather, Sakel interpreted the apparent improvement in psychiatric symptoms as evidence that insulin-induced comas might have therapeutic properties. Sakel's interpretation of this single case, based on a single patient, based on anecdotal observation, based on correlation without any clear understanding of mechanism, would lead him to develop a systematic treatment protocol in which he would deliberately and repeatedly induce insulin comas in psychiatric patients. Sakel spent the following years developing and refining the insulin shock therapy protocol, conducting repeated experiments on psychiatric patients, systematically studying the effects of insulin-induced comas on psychiatric symptoms. Sakel documented his observations, began to publish his findings, and began to promote insulin shock therapy as a potentially effective treatment for schizophrenia. In 1933, Sakel published a detailed description of his insulin shock therapy protocol, outlining how the treatment should be administered, what doses of insulin should be used, how frequently the comas should be induced, how patients should be monitored during the treatment. Sakel's publication of his protocol was influential, was widely read by psychiatrists around the world, and began to establish insulin shock therapy as a potentially valuable treatment option in psychiatric practice. The context in which insulin shock therapy emerged is important for understanding how such a brutal and dangerous treatment could become accepted by the medical establishment. During the 1930s and 1940s, schizophrenia and other serious mental illnesses were viewed as untreatable conditions, as diseases that inevitably led to permanent institutionalization, as conditions for which no effective treatment existed. Patients with schizophrenia were admitted to psychiatric hospitals and often remained institutionalized for the remainder of their lives, confined to institutions, subjected to restraints, subjected to various attempts at treatment that were largely ineffective. The hopelessness surrounding schizophrenia treatment created desperation among psychiatrists, created a situation in which physicians were willing to try almost any intervention that offered even a remote possibility of therapeutic benefit. The emergence of other brutal psychiatric treatments during this same period reflected the same desperation and the same willingness to inflict severe harm in pursuit of hope for therapeutic benefit. Transorbital lobotomy, developed by Walter Freeman in the 1940s, involved the surgical destruction of portions of the brain through the insertion of a leucotome through the eye socket and into the prefrontal cortex. The transorbital lobotomy was an extraordinarily crude surgical procedure, involved no precision, involved the destruction of significant portions of the brain, produced severe personality changes and severe cognitive impairment in patients. Yet transorbital lobotomy became widely adopted in psychiatric institutions, was performed on thousands of patients, was touted as an effective treatment for severe mental illness despite producing severe harm. Insulin shock therapy emerged in this context as an alternative to lobotomy, as a treatment that offered hope for therapeutic benefit without requiring the permanent surgical destruction of brain tissue that lobotomy entailed. Insulin shock therapy was seen by some psychiatrists as a more biological, more scientific approach to psychiatric treatment, an approach that targeted the metabolic and physiological basis of mental illness. The appeal of insulin shock therapy was partly that it did not involve permanent surgical alteration of the brain, partly that the effects were theoretically reversible if the treatment was discontinued, partly that it offered hope of therapeutic benefit without the permanent damage associated with lobotomy. Insulin shock therapy represented what was called biological psychiatry, an approach that sought to treat mental illness through biological interventions rather than through psychotherapy or environmental modifications. The adoption of insulin shock therapy spread rapidly throughout the psychiatric world during the 1930s and 1940s. Psychiatric hospitals in Europe and in North America began to adopt insulin shock therapy, began to develop expertise in administering the treatment, began to subject their patient populations to insulin shock therapy on a systematic basis. The adoption of insulin shock therapy represented a kind of therapeutic enthusiasm, a hope that this treatment might finally offer an effective approach to schizophrenia, a hope that built on the anecdotal observations of apparent improvement that had been reported by Sakel and by other early advocates of insulin shock therapy. The adoption of insulin shock therapy demonstrated the power of hope to overcome ethical concerns, demonstrated how desperation to treat untreatable conditions could lead to the acceptance of dangerous and brutal treatments. The insulin shock therapy protocol that was developed and implemented throughout psychiatric institutions was extraordinarily brutal and extraordinarily dangerous, involving the repeated deliberate induction of life-threatening metabolic crises in vulnerable patients. The protocol typically involved a course of insulin shock therapy consisting of multiple sessions, often 50 to 100 sessions or more, conducted over a period of weeks or months. During each session, the patient would be administered a massive dose of insulin, a dose far larger than any dose that would ever be administered to a diabetic patient for the purpose of managing blood sugar. The insulin dose was calculated to produce severe hypoglycemia, to crash the patient's blood glucose to extremely low levels, to induce unconsciousness and seizures. As the insulin took effect and blood glucose levels crashed, the patient would experience a series of dramatic physiological changes. Initially, the patient would experience symptoms of hypoglycemia, sweating, tremors, rapid heartbeat, anxiety. As blood glucose levels crashed further, the patient would become confused and agitated, would lose consciousness, would experience seizures as the brain reacted to severe glucose deprivation. The seizures could be violent and dangerous, could cause injuries, could last for extended periods. The patient would lie unconscious in a state of severe metabolic crisis with profound hypoglycemia, with the brain essentially starved of the glucose it required to function. The patient would remain in this state of coma for hours, with medical staff monitoring vital signs, monitoring brain activity, waiting to see if the patient would recover spontaneously or if intervention would be necessary. The termination of the insulin-induced coma involved the administration of glucose, typically through intravenous infusion, which would rapidly raise blood glucose levels and allow the patient to regain consciousness. The patient would awaken from the coma confused and disoriented, with no memory of the experience, often in severe distress and agitation, often traumatized by the experience of being chemically forced into unconsciousness. The patient would then be given time to recover, to stabilize, to regain a state of relative normalcy, before being subjected to the same procedure again, typically on the following day or after a brief interval of days. A typical course of insulin shock therapy would involve multiple sessions conducted over a period of weeks. Some protocols involved 50 sessions, some involved 100 sessions or more. Each session involved the induction of severe hypoglycemia and unconsciousness, the seizures, the coma lasting for hours. The repetition of this procedure multiple times, the subjection of patients to this brutal experience dozens or hundreds of times, represented a course of treatment of extraordinary brutality. The accumulation of trauma from repeated insulin-induced comas, the repeated subjection to seizures, and to the terror of losing consciousness, created profound psychological effects on patients subjected to this treatment. The risks associated with insulin shock therapy were substantial and were well recognized even during the period when the treatment was widely practiced. The induction of severe hypoglycemia produced seizures and comas that could cause brain damage, that could cause permanent neurological injury, that could cause death. The mortality rate associated with insulin shock therapy was estimated at around 1% per course of treatment, which meant that if a patient received 100 sessions of insulin shock therapy over a period of months, the cumulative mortality risk from the treatment was substantial. The death rate was not trivial, was not an acceptable risk for a treatment of uncertain benefit, was not justified by the evidence of therapeutic efficacy. Beyond the immediate mortality risk, insulin shock therapy produced various serious adverse effects. Many patients experienced permanent memory loss following insulin shock therapy, lost memories of their lives, lost the ability to form new memories, suffered cognitive impairment that persisted long after the treatment course was completed. Some patients suffered seizure disorders following insulin shock therapy, developed epilepsy as a consequence of the repeated seizures induced by hypoglycemia. Some patients suffered permanent brain damage, developed cognitive deficits, developed personality changes, developed conditions that rendered them profoundly disabled. The severity of the adverse effects that patients experienced from insulin shock therapy was substantial, was life-altering, was often permanent. Despite these risks, insulin shock therapy was widely adopted and was practiced on a massive scale. Psychiatric hospitals competed to adopt insulin shock therapy, competed to develop expertise in administering the treatment, competed for patients who could be subjected to insulin shock therapy. The treatment became a standard practice in psychiatric institutions throughout Europe and North America. Thousands of patients were subjected to insulin shock therapy, were forced to endure repeated insulin-induced comas, were subjected to this brutal treatment in the hope that it might produce therapeutic benefit. The patients who were subjected to insulin shock therapy typically had no choice in whether to undergo the treatment. Many patients were involuntarily committed to psychiatric institutions, were held against their will, were subjected to insulin shock therapy without their consent. Even patients who were in the hospital voluntarily were often unable to refuse insulin shock therapy, were told that insulin shock therapy was the recommended treatment, were subjected to pressure to accept the treatment. The power imbalance between patients and psychiatric institutions was extreme, was absolute, was such that patients had no effective mechanism to refuse treatment or to demand alternative approaches. The subjective experience of patients undergoing insulin shock therapy was one of profound terror and trauma. Patients described insulin shock therapy as torture, described the experience of being deliberately forced into unconsciousness, described the seizures, described the confusion upon awakening. Some patients reported attempting to refuse further insulin shock therapy, reported begging to be spared from additional sessions, reported experiencing severe anxiety and fear in anticipation of each session. The psychological trauma caused by insulin shock therapy was as significant as the physical damage, was as life-altering, was often as permanent as the physical effects of the treatment. The medical community's response to the adverse effects and dangers associated with insulin shock therapy was to largely ignore or minimize the evidence of harm. When patients died from insulin shock therapy, when patients suffered brain damage or permanent memory loss, when patients reported extreme trauma, the medical establishment's response was typically to view these outcomes as inevitable costs of a potentially beneficial treatment. The ideology that justified insulin shock therapy involved the belief that mental illness was so severe, so devastating, that almost any risk was justified if there was a possibility of therapeutic benefit. The ideology involved the view that psychiatric patients deserved little concern regarding their welfare, that the benefits to society of potentially treating schizophrenia outweighed the costs to individual patients of subjecting them to brutal and dangerous treatment. The evidence regarding the therapeutic efficacy of insulin shock therapy was, in fact, quite weak and was based largely on anecdotal observations and on poorly designed studies. Some patients did appear to experience some improvement in psychiatric symptoms following insulin shock therapy. Some patients did appear to have remission of psychotic symptoms after completing a course of insulin shock therapy. However, the evidence for improvement was largely anecdotal, was based on retrospective observations by psychiatrists administering the treatment, was not based on rigorous controlled studies comparing insulin shock therapy to other treatments or to no treatment. The anecdotal reports of improvement could be explained by spontaneous remission, by the placebo effect, by the natural history of schizophrenia, which frequently involves periods of remission even without treatment. The question of mechanism, how insulin shock therapy might produce therapeutic benefit, was never clearly answered. The theories proposed ranged from the vague to the implausible. Some psychiatrists proposed that the trauma of the insulin-induced coma might somehow reset the brain's neurochemistry, might shock the brain out of its disordered state, might produce some kind of neurological reorganization that would improve psychiatric symptoms. Others proposed that the physiological stress produced by the hypoglycemia might activate adaptive responses that would improve psychiatric symptoms. Still others simply acknowledged that they did not understand how insulin shock therapy worked, but that the treatment appeared to produce some benefit based on their observations. The absence of a clear mechanism for how insulin shock therapy might work did not deter its widespread adoption and use. Rather, the mystery of the treatment became part of its appeal, became part of the justification for its use. If the mechanism was unknown, then certainly more research was justified. Certainly more patients should be subjected to the treatment to gather more data. Certainly insulin shock therapy should remain in the arsenal of psychiatric treatments pending further investigation. The absence of clear evidence of efficacy, the absence of clear understanding of mechanism, did not lead to the rejection of insulin shock therapy or to its cautious use only in well-controlled research settings. Rather, insulin shock therapy was adopted enthusiastically by psychiatric institutions around the world and was practiced on a massive scale. The peak use of insulin shock therapy occurred in the 1940s and 1950s, a period during which insulin shock therapy was one of the primary treatments offered by psychiatric institutions for schizophrenia and for other serious mental illnesses. During this period, thousands of patients were subjected to insulin shock therapy every year, were forced to endure repeated insulin-induced comas, were subjected to this brutal treatment in psychiatric institutions worldwide. The widespread adoption of insulin shock therapy during this period represents a kind of collective delusion, a period during which the psychiatric establishment convinced itself that a brutal and dangerous treatment was justified, that the risks were acceptable, that the hope of therapeutic benefit outweighed the certainty of trauma and the substantial risk of serious harm. The development of insulin shock therapy had also encouraged the development of other physically traumatic psychiatric treatments. Cardiazol shock therapy, which involved the intravenous injection of a substance that produced severe convulsions and unconsciousness, was developed as an alternative to insulin shock therapy. Cardiazol shock therapy involved many of the same risks as insulin shock therapy, produced seizures and unconsciousness, had a mortality rate, produced permanent brain damage in some patients. Electroconvulsive therapy, which involved the use of electrical current to induce seizures, was also developed during this period and was viewed as another biological approach to psychiatric treatment. All of these treatments involved the deliberate induction of severe physiological crises. All were justified by the hope that trauma might produce therapeutic benefit. All involved the subjection of vulnerable patients to brutal treatment. The patients who were subjected to insulin shock therapy were among the most vulnerable members of society. Many were individuals with schizophrenia, with severe and persistent mental illness, with few resources, with few advocates. Many were involuntarily committed to psychiatric institutions, were held against their will, were subjected to treatment without their consent. Many were poor, many were socially marginal, many had no family members or advocates who would defend their interests. The combination of vulnerability, of lack of power, of lack of advocacy, created a situation in which patients could be subjected to brutal treatment with little concern for their welfare or their rights. The expansion of insulin shock therapy throughout psychiatric institutions during the 1940s and 1950s represented a massive public health experiment, an experiment conducted on psychiatric patients without their informed consent, an experiment with no clear hypothesis, no clear control groups, no clear methodology. Psychiatric institutions in the United States, in Europe, in other regions of the world began to adopt insulin shock therapy, began to treat their patient populations with this brutal and dangerous treatment. Hospitals purchased equipment and trained staff to administer insulin shock therapy. Hospital budgets were allocated to support insulin shock therapy. Professional conferences featured presentations about insulin shock therapy. The psychiatric literature was filled with publications about insulin shock therapy. The enthusiasm for insulin shock therapy was extraordinary and was based on hope rather than on clear evidence. The adoption of insulin shock therapy was particularly rapid in the United States, where psychiatric institutions began to systematically subject patients to insulin shock therapy on a large scale. American psychiatric hospitals, particularly state psychiatric hospitals that housed poor and vulnerable populations, began to treat psychiatric patients with insulin shock therapy as a routine part of their treatment programs. Some psychiatric hospitals made insulin shock therapy the primary treatment available to patients. Some hospitals subjected hundreds or thousands of patients to insulin shock therapy over a period of years. The subjection of such large numbers of patients to this brutal and dangerous treatment represented one of the largest medical abuses of the 20th century. The justification for insulin shock therapy was often framed in terms of the need for aggressive treatment of severe mental illness, in terms of the belief that schizophrenia was such a terrible condition that almost any risk was justified in attempting to treat it. The rhetoric surrounding insulin shock therapy often emphasized the desperation of the situation, the lack of other treatment options, the need to try new approaches even if the risks were substantial. The rhetoric involved the view that psychiatric patients were essentially beyond the normal protections of medicine, that psychiatric patients could be subjected to treatments that would never be considered acceptable for other patient populations, that the rules of medical ethics were somehow different for psychiatric patients. The administration of insulin shock therapy involved various risks beyond the direct risks of inducing severe hypoglycemia. The administration of insulin required skill and careful dosing, required careful monitoring of blood glucose levels, required rapid access to glucose in case of emergency. Errors in insulin dosing, errors in monitoring, delays in administering glucose could result in prolonged severe hypoglycemia, could cause permanent brain damage or death. Some patients died from insulin shock therapy due to errors in administration, due to complications during the procedure, due to the inherent risks of the treatment. The deaths that occurred from insulin shock therapy were often not fully reported, were often minimized, were often attributed to the patient's underlying psychiatric condition rather than to the treatment itself. The psychological preparation of patients for insulin shock therapy was minimal or non-existent. Patients were often not informed about what would happen to them, were often not warned about the seizures and unconsciousness they would experience, were often not given any psychological preparation for the trauma they would endure. Some patients were essentially tricked into accepting insulin shock therapy, were told that the treatment would help them without being informed about the actual nature of the treatment. The lack of informed consent, the lack of psychological preparation, the failure to respect patients' autonomy and dignity represented serious ethical violations. The experience of patients during insulin shock therapy was uniformly described as extremely unpleasant. Patients reported intense fear in anticipation of each session, reported the terror of losing consciousness, reported the seizures and the violent movements of their bodies during the coma, reported confusion and disorientation upon awakening. Some patients reported amnesia for much of their lives, reported losing the ability to form new memories, reported profound cognitive changes following insulin shock therapy. Some patients reported depression and despair, reported that insulin shock therapy was worse than the psychiatric symptoms they had suffered from before the treatment, reported that they would have preferred to remain untreated rather than to endure insulin shock therapy. The documentation of adverse effects from insulin shock therapy was inadequate. When patients suffered memory loss, when patients suffered brain damage, when patients suffered permanent cognitive impairment, these adverse effects were often not documented, were often not reported, were often dismissed as inevitable consequences of treatment or as manifestations of the patient's underlying psychiatric condition. The medical records of patients who received insulin shock therapy often contained minimal information about the treatment, about the doses administered, about the number of sessions, about any adverse effects experienced. The lack of documentation made it difficult for subsequent researchers to fully assess the extent of harm caused by insulin shock therapy. The theoretical justifications for insulin shock therapy underwent various modifications as the treatment became more widely adopted and as evidence of its limitations became apparent. Early in the history of insulin shock therapy, the justification was based on Sakel's original observation that apparent psychiatric improvement seemed to follow insulin-induced comas. As more experience accumulated and as inconsistent results were observed, the theoretical justifications became more elaborate. Some psychiatrists proposed that insulin shock therapy worked through some kind of metabolic reset, that the severe hypoglycemia and the coma disrupted the brain's pathological function and allowed it to reorganize in a more normal way. Others proposed that insulin shock therapy worked through a conditioning mechanism, that the trauma of the treatment somehow conditioned the brain to produce more normal functioning. Still others proposed that the beneficial effects of insulin shock therapy were related to nonspecific factors, to the attention given to patients during treatment, to the placebo effect, to the natural course of psychiatric illness. The diversity of theoretical justifications, the lack of consensus about how insulin shock therapy might work, the absence of any clear mechanism reflected the fundamental problem with insulin shock therapy. It was never clearly demonstrated to work, was never subjected to rigorous scientific evaluation, was adopted and practiced based largely on hope and on anecdotal observations. The development of various theoretical justifications represented an attempt to rationalize a treatment that was not actually based on clear scientific evidence, represented an attempt to provide a scientific-sounding explanation for why psychiatrists believed the treatment was beneficial even though the evidence was weak. The comparison between insulin shock therapy and other psychiatric treatments during the same period is instructive. Electroconvulsive therapy, which involved the use of electrical current to induce seizures, produced some of the same risks as insulin shock therapy, but was perhaps more acceptable to some psychiatrists because the mechanism seemed more direct. The induced seizure could theoretically affect brain chemistry or brain organization. Psychosurgery, particularly transorbital lobotomy, was viewed by some as more effective than insulin shock therapy because it produced more definite personality changes, even though these changes often represented severe impairment rather than improvement. The competition among these various brutal treatments reflected the desperation surrounding psychiatric treatment, the absence of effective treatment options, the willingness to inflict severe harm in pursuit of hoped-for therapeutic benefit. The attitudes of psychiatrists administering insulin shock therapy often reflected a kind of moral numbness, a detachment from the humanity of their patients, a capacity to cause severe harm while maintaining the belief that they were acting in patients' best interests. Many psychiatrists who administered insulin shock therapy described themselves as helping their patients, described insulin shock therapy as a kindness, described the treatment as the best option available for severe psychiatric illness. The capacity to describe the deliberate induction of life-threatening metabolic crises as a kindness, the capacity to cause severe trauma while believing oneself to be helping, represented a kind of psychological defense mechanism, represented a way of maintaining self-image as a good person and a good physician while engaging in actions that caused severe harm. The power dynamics between patients and psychiatrists, between patients and psychiatric institutions, were fundamentally unequal. Patients had no power, no ability to refuse treatment, no mechanism to appeal to higher authorities if they objected to treatment. The psychiatric institution had absolute power over patients, had the power to confine them against their will, had the power to subject them to any treatment the institution deemed appropriate. The absolute power of the institution over patients, combined with the vulnerability of patients, created a situation in which patients could be abused with minimal risk of consequences. The isolation of psychiatric patients from society, the stigma associated with psychiatric illness, the marginalization of psychiatric patients, meant that abuses within psychiatric institutions were unlikely to be reported, were unlikely to be prosecuted, were unlikely to result in consequences for those responsible. The continuation of insulin shock therapy, despite increasing awareness of its dangers and limitations, represented a kind of institutional inertia, a reluctance to abandon treatments that had become standard practice, a failure of medical ethics and medical science to protect vulnerable patients from harm. As evidence accumulated that insulin shock therapy was not actually effective, as more information became available about the severe adverse effects of the treatment, as more patients reported traumatic experiences, the medical establishment did not respond by abandoning the treatment or by restricting its use to carefully controlled research settings. Rather, insulin shock therapy continued to be used, continued to be adopted by new institutions, continued to be administered to thousands of patients every year. The documentation of deaths from insulin shock therapy accumulated over the years and decades of the treatment's use. Various studies and reports noted that patients did die from insulin shock therapy, that the mortality rate was not zero, that the risk of death was a real concern. However, the response to this evidence of mortality was not to abandon the treatment, was not to severely restrict its use, was not to require informed consent from patients before subjecting them to the treatment. Rather, the response was typically to accept the mortality as an unfortunate but inevitable consequence of treatment, to view the deaths as acceptable risks given the hope of therapeutic benefit, to continue administering the treatment to new patients. The documentation of permanent brain damage and memory loss from insulin shock therapy also accumulated over the years. Various case reports and studies documented patients who suffered severe cognitive impairment following insulin shock therapy, patients who lost years or decades of memories, patients who could no longer function in society because of the cognitive damage they had sustained. However, the response to this evidence of permanent harm was not to abandon the treatment or to severely restrict its use. Rather, the response was typically to minimize the significance of these adverse effects, to attribute them to the patient's underlying psychiatric condition rather than to the treatment, to continue administering the treatment to new patients. The development of alternative treatments during the 1950s provided a turning point in the history of insulin shock therapy. In 1952, chlorpromazine was developed, a medication that could reduce the symptoms of schizophrenia without requiring the induction of life-threatening metabolic crises, without producing seizures or unconsciousness, without the severe adverse effects associated with insulin shock therapy. Chlorpromazine was not a perfect treatment. It had its own adverse effects. It did not work for all patients. It did not cure schizophrenia. However, chlorpromazine offered a far less dangerous and far less traumatic alternative to insulin shock therapy. The development of chlorpromazine and other antipsychotic medications began to make insulin shock therapy obsolete. The response of the psychiatric establishment to the development of effective antipsychotic medications was remarkable in its lack of contrition or acknowledgement of past harm. Rather than acknowledging that insulin shock therapy had been a mistake, rather than apologizing to patients who had been subjected to the treatment, rather than examining how such a brutal and ineffective treatment had become so widely practiced, the psychiatric establishment simply moved on to new treatments. Insulin shock therapy was quietly discontinued in many psychiatric institutions, was abandoned in practice without any formal acknowledgement of the treatment's lack of efficacy or of the harm it had caused to patients. The historical moment at which insulin shock therapy was abandoned, the early to mid-1950s, represented a critical juncture at which the psychiatric profession could have engaged in serious reflection about how such a harmful treatment had been adopted so widely, about the ethical failures that had allowed the treatment to continue despite evidence of harm, about the need for reforms in psychiatric care and in medical ethics. However, the psychiatric profession largely failed to engage in this kind of critical reflection. Rather, the profession moved on to new treatments, adopted the new antipsychotic medications, began to shift the focus of psychiatric treatment toward pharmacological approaches. The failure to acknowledge the harms of insulin shock therapy, the failure to apologize to patients who had been subjected to the treatment, the failure to examine the ethical failures that had allowed the treatment to continue represented a missed opportunity for meaningful reform in psychiatric practice. The discontinuation of insulin shock therapy did not mean that the broader patterns that had allowed insulin shock therapy to flourish were addressed or reformed. The patterns of desperation, the willingness to adopt brutal and dangerous treatments based on weak evidence, the tendency to prioritize hope over evidence, the power imbalances between patients and institutions, the lack of informed consent, the marginalization of psychiatric patients, all of these patterns continued to characterize psychiatric practice. The discontinuation of insulin shock therapy was followed by the continued use of other physically traumatic treatments, including electroconvulsive therapy and various forms of psychosurgery. The patterns that had allowed insulin shock therapy to flourish continued to allow other harmful treatments to be practiced on vulnerable psychiatric patients. The historical record of insulin shock therapy was gradually buried and forgotten. Medical textbooks that had enthusiastically endorsed insulin shock therapy in the 1940s and 1950s began to omit any mention of the treatment in subsequent editions. Medical historians largely ignored insulin shock therapy or mentioned it only briefly. The survivors of insulin shock therapy, the patients who had been subjected to the treatment and who carried the permanent psychological and physical scars, found that few people wanted to hear about their experiences. Few people wanted to acknowledge what had been done to them. The erasure of insulin shock therapy from medical consciousness and from public awareness represented a kind of collective forgetting, represented a way of moving forward without addressing past harms. The treatment of insulin shock therapy by the medical profession after its discontinuation reflected a pattern that would be repeated with other harmful psychiatric practices. Rather than acknowledging past harms, rather than apologizing to patients, rather than implementing systemic reforms to prevent similar abuses in the future, the medical profession simply moved on. The failure to acknowledge past harms, the failure to engage in critical reflection about the causes of the harms, the failure to implement reforms meant that the patterns that had allowed insulin shock therapy to flourish remained in place, remained available to support other harmful practices, remained embedded in psychiatric institutions and in psychiatric culture. The rediscovery of insulin shock therapy as a historical case study occurred only decades later, primarily through the efforts of historians and through the emergence of survivor testimonies. In the 1990s and 2000s, historians of medicine began to examine the history of insulin shock therapy, began to document the scale of the practice, began to document the adverse effects and the mortality associated with the treatment. Survivors of insulin shock therapy began to share their experiences, began to come forward to describe the trauma they had endured, began to seek recognition and acknowledgement of the harms they had suffered. The emergence of these survivor testimonies and the historical research documenting insulin shock therapy made clear that a massive medical abuse had occurred, that hundreds of thousands of patients had been subjected to brutal and dangerous treatment, that the medical profession had largely forgotten or ignored this history. The recognition of insulin shock therapy as a historical abuse had various consequences. Medical schools began to teach the history of insulin shock therapy as a cautionary tale, as an example of how medical practice could go wrong, as an illustration of the dangers of desperation and hope overriding evidence. Medical ethicists began to study insulin shock therapy as a case study in medical ethics, as an example of how ethical constraints could be abandoned, as an illustration of how vulnerable patients could be harmed with minimal consequences for those responsible. Institutional review boards and other oversight mechanisms for research and treatment protocols were partly developed in response to recognizing historical abuses like insulin shock therapy, were developed to prevent similar abuses from occurring in the future. The emergence of the requirement for informed consent in medical practice, the development of more rigorous standards for evaluating the efficacy of treatments, the development of institutional review boards to oversee research and treatment protocols, all of these developments in medical ethics and in medical practice were partly responses to historical abuses, including insulin shock therapy. The patients who had been subjected to insulin shock therapy, despite suffering permanent harm, had contributed to improvements in medical ethics and in the protection of vulnerable patients. The recognition of insulin shock therapy as a historical abuse represented a kind of validation of the suffering that patients had endured, represented an acknowledgement that what had been done to them was wrong, even though it came decades after the fact. The comparison between insulin shock therapy and other harmful psychiatric practices reveals patterns that recur in the history of psychiatry and in the history of medicine more broadly. Transorbital lobotomy, like insulin shock therapy, was adopted widely despite weak evidence of efficacy, was administered to thousands of patients, caused severe harm and permanent disability, was eventually abandoned. Electroconvulsive therapy remains in use in contemporary psychiatric practice despite ongoing concerns about efficacy and about adverse effects including memory loss. The pattern that emerges is one in which desperation to treat serious mental illness, combined with weak evidence and power imbalances favoring institutions over patients, creates conditions under which harmful treatments can be adopted and widely practiced. The persistence of electroconvulsive therapy into contemporary psychiatry, despite the history of insulin shock therapy and despite ongoing concerns about the treatment's safety and efficacy, suggests that the lessons of insulin shock therapy may not have been fully learned. Electroconvulsive therapy involves the induction of seizures using electrical current, produces unconsciousness and seizures, produces some of the same risks as insulin shock therapy including memory loss and cognitive impairment, yet continues to be used and even advocated by some in the psychiatric field. The continued use of electroconvulsive therapy despite its risks and despite the history of similar harmful practices suggests that the patterns that allowed insulin shock therapy to flourish have not been fully addressed. The role of pharmaceutical companies in the transition away from insulin shock therapy toward psychopharmacology was significant but is often overlooked. The development of chlorpromazine and other antipsychotic medications was driven partly by pharmaceutical companies seeking to develop profitable medications, was marketed aggressively to psychiatric institutions and to psychiatrists, was promoted as superior to previous treatments. The shift from insulin shock therapy to antipsychotic medications was not primarily driven by ethical concerns about the harms of insulin shock therapy, but rather by the availability of alternative treatments that could generate profits for pharmaceutical companies. The role of profit motive in driving changes in psychiatric practice, the influence of pharmaceutical companies on psychiatric education and practice, represents another dimension of the history that relates to insulin shock therapy. The survivors of insulin shock therapy carried the physical and psychological scars of the treatment for the remainder of their lives. Many survivors suffered permanent memory loss, suffered permanent cognitive impairment, suffered ongoing psychological trauma from the treatment they had endured. Many survivors reported that insulin shock therapy was worse than the psychiatric symptoms they had experienced, reported that they would have preferred to remain untreated. The loss of years or decades of memories, the inability to form new memories, the cognitive impairment that persisted for life, represented a permanent loss that could never be restored, that could never be fully compensated. The absence of reparations or meaningful compensation for survivors of insulin shock therapy represented a failure of justice and accountability. While some survivors eventually received some form of compensation or acknowledgement, many received nothing. Many died without any recognition that they had been harmed, without any apology from the institutions that had harmed them. The failure to provide reparations, the failure to acknowledge the severity of the harms caused, the failure to hold those responsible accountable, represented a failure of the medical profession and of the broader society to acknowledge past wrongs and to make amends. The story of insulin shock therapy represents a cautionary tale about the dangers of desperation, about the dangers of hope overwhelming evidence, about the dangers of power imbalances between institutions and vulnerable patients. The story illustrates how medical practice can go wrong when evidence-based approaches are abandoned in favor of hope and desperation, when vulnerable patients lack power to refuse harmful treatments, when institutions and the professionals within them prioritize hope over the welfare of patients. The story of insulin shock therapy illustrates the necessity of ethical constraints on medical practice, the necessity of informed consent, the necessity of rigorous evaluation of treatments before they are widely adopted, the necessity of protecting vulnerable patients from harm. The broader context in which insulin shock therapy emerged and flourished illuminates important truths about psychiatric institutions and about the treatment of mental illness in 20th century society. Psychiatric institutions in this period were sites of tremendous power imbalances, were places where vulnerable people with serious mental illness were confined against their will, were places where institutional authority was absolute and unchecked. The patients in psychiatric institutions were often poor, often lacked family support, often had no advocates, often were removed from society and isolated from the broader population. The combination of vulnerability, isolation, and absolute institutional power created conditions under which patients could be subjected to brutal treatments with minimal concern for their welfare or their rights. The institutional structures that facilitated insulin shock therapy, the absence of meaningful oversight, the absence of requirements for informed consent, the power of psychiatrists to determine treatment without patient input, the isolation of patients from the broader society, reflected broader patterns in 20th century psychiatry. Psychiatric institutions were often run with minimal oversight, with little external scrutiny, with little accountability for what occurred within the institution. The psychiatric profession's claim to medical expertise created a situation in which the institution's practices were largely trusted to be in patients' best interests, were rarely questioned by external authorities, were rarely subjected to meaningful oversight or scrutiny. The adoption and practice of insulin shock therapy occurred within this broader context of psychiatric institutions operating with minimal oversight and minimal accountability. The enthusiasm for insulin shock therapy among some psychiatrists was enabled by the absence of meaningful constraints on what treatments could be practiced within psychiatric institutions. The continuation of insulin shock therapy despite evidence of harm was enabled by the absence of external oversight, by the isolation of psychiatric institutions from broader scrutiny, by the power imbalances between patients and psychiatrists. The eventual discontinuation of insulin shock therapy was not primarily driven by ethical concerns or by external oversight, but rather by the development of alternative treatments that were viewed as more convenient or more effective. The documentation of insulin shock therapy in the historical record was largely created by the psychiatrists who practiced the treatment, was largely presented from the perspective of those administering the treatment rather than from the perspective of patients subjected to it. The early publications about insulin shock therapy, the case reports, the theoretical discussions were written by psychiatrists promoting the treatment, were written to justify the treatment and to encourage its adoption by other psychiatrists. The perspective of patients, their experiences of trauma, their suffering, their objections to the treatment, was largely absent from the medical literature, was rarely documented, was rarely considered significant by those writing about the treatment. The recovery of patient perspectives on insulin shock therapy occurred only much later, primarily through oral histories and survivor testimonies that emerged decades after the treatment had been discontinued. These survivor testimonies provided a fundamentally different perspective on insulin shock therapy, documented the profound trauma experienced by patients, documented the permanent harm caused by the treatment, documented the absolute lack of consent from patients subjected to the treatment. The emergence of these survivor testimonies made clear that the historical record created by psychiatrists promoting insulin shock therapy had been profoundly incomplete and had largely erased the experiences of those most affected by the treatment. The failure of the medical profession to adequately document adverse effects from insulin shock therapy, the failure to acknowledge the harms caused, the failure to apologize to patients, represented a serious failure of medical ethics and professional responsibility. The medical profession's obligation includes the obligation to acknowledge mistakes, to recognize when treatments have caused harm, to take responsibility for harms caused. The failure of the psychiatric profession to fully acknowledge the harms of insulin shock therapy, even after the treatment had been discontinued, and after evidence of its inefficacy had accumulated, represented a failure of these basic professional obligations. The development of informed consent requirements in medical practice was partly driven by recognition of abuses like insulin shock therapy, was partly a response to the historical reality that vulnerable patients had been subjected to brutal treatments without their knowledge or consent. The Nuremberg Code, developed in response to Nazi medical atrocities during World War II, established the principle that informed consent was a prerequisite for medical research and medical treatment. The Declaration of Helsinki and subsequent ethical guidelines for medical research built on these principles, establishing standards for informed consent that were intended to protect vulnerable research subjects and patients from harm. The application of these informed consent principles to psychiatric practice occurred only gradually and remains incomplete even in contemporary practice. Psychiatric patients continue to have limited power to refuse treatments, continue to be subjected to involuntary treatment in some contexts, continue to face barriers to informed decision-making. The legacy of insulin shock therapy and of other harmful psychiatric practices remains visible in the continued vulnerability of psychiatric patients, in the continued power imbalances between patients and psychiatric institutions, in the continued ability of psychiatrists to override patients' wishes and to impose treatments against patients' objection. The role of institutional review boards and other oversight mechanisms in preventing abuses like insulin shock therapy is significant but is also limited. These oversight mechanisms can review protocols for research and for treatment, can require that informed consent be obtained, can monitor for adverse effects. However, institutional review boards are themselves embedded within institutions, are often staffed by people with interests in advancing the institution's goals, may not provide the kind of external oversight that would be necessary to prevent abuses. The effectiveness of institutional review boards in protecting vulnerable patients remains contested and unclear. The international dimensions of insulin shock therapy reflect the spread of psychiatric practices across borders and the relative lack of international oversight of psychiatric practice. Insulin shock therapy was adopted not only in psychiatric institutions in the United States and in Europe, but also in psychiatric institutions in Latin America, in Asia, in other regions of the world. The international adoption of insulin shock therapy meant that the treatment affected patients in multiple countries, affected patients from diverse cultural backgrounds, affected patients in institutions with even less oversight and even fewer protections than existed in wealthy Western countries. The economic dimensions of insulin shock therapy are also significant. The equipment required to administer insulin shock therapy, the insulin itself, the staffing required, the hospitalization required, all of these created costs that made insulin shock therapy a significant economic enterprise for psychiatric institutions. The adoption of insulin shock therapy was driven partly by the economic incentives created by the costs of the treatment, by the fees that could be charged for administration of the treatment, by the length of hospitalization required. The economic interests in continuing insulin shock therapy, even as evidence of inefficacy accumulated, may have contributed to the treatment's persistence despite growing awareness of its limitations. The relationship between insulin shock therapy and the development of the psychiatric profession itself is worth examining. Insulin shock therapy created opportunities for psychiatrists to claim expertise in a sophisticated biological treatment, to position psychiatry as a medical specialty with genuine therapeutic interventions. The adoption of insulin shock therapy by psychiatric institutions represented a kind of medicalization of psychiatric care, a shift from purely custodial care toward more active treatment. The biological approach represented by insulin shock therapy aligned with broader trends in medicine toward viewing disease as having biological bases and toward treating disease through biological interventions. The emergence in the late 20th and early 21st centuries of critical historical scholarship on insulin shock therapy and on other harmful psychiatric practices represents an important development in how medicine and psychiatry relate to their own histories. This scholarship, conducted by historians of medicine, by medical ethicists, by survivors and their advocates, has made clear that insulin shock therapy represented a massive medical abuse, has documented the scale of the practice, has documented the harms caused, has brought the experiences of survivors into the historical record. This historical work has made clear what psychiatric institutions and psychiatric professionals often preferred to keep hidden, that harmful practices have been widespread in psychiatry, that vulnerable patients have been subjected to brutal treatments, that the history of psychiatry includes episodes of profound moral failure. The role of survivor activists and survivor advocacy organizations in bringing attention to insulin shock therapy and in demanding recognition and accountability has been crucial. Survivors of insulin shock therapy and of other harmful psychiatric practices have organized, have shared their testimonies, have demanded that the medical profession acknowledge what was done to them, have demanded accountability from institutions and from individual practitioners. The advocacy efforts of survivors have created pressure on medical institutions to acknowledge past harms, have contributed to the development of ethical frameworks for psychiatric care, have influenced the training of mental health professionals to recognize the dangers of harmful practices. The documentation of insulin shock therapy in contemporary medical education represents a significant change from the earlier period when the treatment was barely mentioned in medical textbooks. Contemporary medical students and psychiatric residents are taught about insulin shock therapy as a historical example of a harmful practice, are taught to recognize the patterns that allowed the practice to flourish, are taught to understand the ethical principles that should have prevented the adoption of such a harmful treatment. The inclusion of insulin shock therapy in medical education represents an attempt to learn from history, to recognize the dangers of repeating patterns from the past, to prepare future physicians to recognize and resist harmful practices. The legal dimensions of insulin shock therapy have also emerged in recent decades. Some survivors of insulin shock therapy have sought legal redress, have filed lawsuits against psychiatric institutions and against individual practitioners, have sought compensation for the harms they endured. Some lawsuits have been successful, have resulted in financial compensation for survivors, have resulted in judgments against institutions that admitted responsibility for harms caused. However, many cases have been barred by statutes of limitations, have encountered legal obstacles, have failed to achieve justice for survivors. The limited success of legal actions on behalf of survivors represents another dimension of the failure of justice and accountability regarding insulin shock therapy. The international dimensions of accountability for insulin shock therapy remain largely unaddressed. In many countries where insulin shock therapy was practiced, little effort has been made to document the extent of the practice, to identify survivors, to provide acknowledgement or compensation for harms caused. The international adoption of insulin shock therapy meant that patients in many countries suffered the effects of this brutal treatment, yet in many countries there has been little historical reckoning, little acknowledgement of what was done, little effort to hold institutions and individuals accountable. The lack of international accountability represents another dimension of the failure of justice regarding insulin shock therapy. The broader question of how societies address historical abuses in medicine and psychiatry remains incompletely resolved. The recognition of insulin shock therapy as an abuse occurred decades after the treatment was discontinued, decades after patients had suffered permanent harm. The mechanisms for identifying abuses, for investigating them, for holding those responsible accountable, for providing reparations to those harmed remain inadequate. The hope that the recognition of insulin shock therapy as an abuse would lead to the development of better mechanisms for preventing similar abuses has been only partially realized. The patterns that allowed insulin shock therapy to flourish, desperation, hope, overwhelming evidence, power imbalances between institutions and patients, isolation of vulnerable populations, remain present in contemporary psychiatry and remain capable of supporting harmful practices. The story of insulin shock therapy stands as a profound historical warning, a warning about the dangers of desperation, about the dangers of hope overwhelming evidence, about the dangers of abandoning ethical principles in pursuit of hoped-for therapeutic benefit. The story illustrates clearly that medical institutions, even well-intentioned institutions, can engage in massive abuses when proper constraints are absent, when vulnerable patients lack power to resist, when the medical profession fails to maintain ethical standards. The story demonstrates the necessity of informed consent, of rigorous evaluation of treatments, of meaningful oversight of medical practice, of protection for vulnerable patients from harm. The suffering of those who endured insulin shock therapy was profound and lasting. The patients who were subjected to this brutal treatment carried the physical and psychological scars for the remainder of their lives, lost memories that could never be recovered, suffered cognitive impairment that persisted, suffered trauma that was never adequately addressed. Many of these patients died without receiving acknowledgement that what had been done to them was wrong, without receiving apology or reparations, without seeing meaningful accountability for the institutions and individuals who had harmed them. The failure to provide adequate justice and acknowledgement for those harmed by insulin shock therapy represents a continuing failure of medical ethics and of societal responsibility. The legacy of insulin shock therapy extends beyond those who directly experience the treatment. The legacy includes the broader impacts on psychiatric institutions, on psychiatric practice, on how vulnerable patients are treated in medical contexts. The legacy includes the patterns of desperation, hope, and institutional power that enabled insulin shock therapy and that continue to enable harmful practices in contemporary psychiatry. The recognition of insulin shock therapy as an abuse represents an important historical moment, an important acknowledgement of how medicine can go wrong, an important opportunity to reflect on what must change to prevent similar abuses in the future. The development of more rigorous standards for evaluating treatments, the development of informed consent requirements, the development of institutional oversight mechanisms, the inclusion of medical ethics in medical education. All of these developments represent partial responses to the historical reality of insulin shock therapy and other harmful practices. However, these developments remain incomplete, their implementation remains inconsistent, their effectiveness in protecting vulnerable patients remains uncertain. The continued vulnerability of psychiatric patients, the continued power imbalances in psychiatric care, the continued ability of institutions to override patients' wishes, all suggest that the lessons of insulin shock therapy have not been fully learned or fully implemented. The role of documentation and historical memory in preventing the repetition of abuses like insulin shock therapy is significant. The fact that insulin shock therapy is now remembered as an abuse, that it is documented in historical scholarship, that survivors' testimonies are preserved, means that future generations can learn about what occurred, can recognize similar patterns if they emerge, can understand the dangers of repeating history. However, the risk of forgetting these lessons, of allowing historical memory to fade, of failing to transmit these lessons to new generations, remains real and significant. The continued effort to maintain historical memory about insulin shock therapy, to keep the survivors' stories alive, to transmit the lessons learned to future generations, represents an important ongoing obligation. The question of what compensation and recognition should be provided to survivors of insulin shock therapy remains incompletely addressed. While some survivors have received financial compensation, many have received nothing. While some recognition has been provided, many survivors have been forgotten. The debt owed to those who suffered insulin shock therapy, the debt of acknowledgement, of apology, of compensation, of institutional reform, remains substantial and remains only partially paid. The continuing failure to adequately address this debt represents a continuing failure of justice and institutional responsibility. The broader implications of the insulin shock therapy history for contemporary medical practice and for the treatment of mental illness remain significant and remain worthy of sustained reflection. The history demonstrates that desperation to treat serious mental illness, while understandable and while driven by genuine concern for patients, can lead to abandonment of ethical principles if not constrained by rigorous standards, by meaningful oversight, by protection for patient autonomy and informed consent. The history demonstrates that vulnerable populations, those with mental illness, those who are poor, those who lack social power, require special protection from institutional harm, require explicit legal and ethical frameworks to prevent abuse, cannot be relied upon to protect themselves from powerful institutions. The development of recovery-oriented approaches to mental illness, the development of psychosocial interventions alongside pharmacological approaches, the increasing emphasis on shared decision-making and on respecting patient autonomy in psychiatric care all represent responses to the historical lessons of insulin shock therapy and of other harmful practices. However, the implementation of these principles remains inconsistent, remains contested, remains threatened by economic pressures, by desperation, by the continuing tendency to prioritize hoped-for therapeutic benefit over patient welfare and patient autonomy. The story of insulin shock therapy ultimately represents a story about human vulnerability, about the capacity of institutions and individuals to harm the vulnerable when constraints are absent, about the necessity of vigilant protection of the most vulnerable members of society. The story stands as a reminder that good intentions do not prevent harm, that institutional authority can be exercised harmfully even by well-meaning individuals, that the protection of vulnerable patients requires explicit legal and ethical frameworks, meaningful oversight, genuine respect for patient autonomy, and informed consent. The survivors of insulin shock therapy, through their suffering and through their courage in sharing their stories, have provided a legacy of warning, a legacy of instruction, a legacy of demand for accountability and for transformation of practices that harm the vulnerable.